Welcome, everyone. I'm Claire Eden. I think I know a lot of folks. I see a lot of people that I consider to be colleagues and mentors in the audience. So I hope you'll all weigh in on this topic as I discuss assessing breastfeeding in the premature or ill infant. My name is Claire Eden. I'm a board certified lactation consultant, and I am the program director for the Educating Physicians in Their Communities, or EPIC breastfeeding education program, which is the educational partner of the GaPQC's neonatal initiative, Optimizing Newborn Nutrition. And I hope that those of you who don't work in the NICU will stick around, because one of our objectives in the Optimizing Newborn Nutrition initiative is to reduce siloing between units in your hospital. So if you don't work in the NICU, this will be a good learning opportunity, I hope. So we're going to start with kind of agreeing that breastfeeding and human milk are the normative standards for infant feeding and nutrition. And it seems obvious, but I think because the neonatal intensive care unit is not normal, that oftentimes we forget that breastfeeding and human milk are the normative standards. And according to the AAP, the short and long-term medical and neurodevelopmental advantages of breastfeeding make breastfeeding or the provision of human milk a public health imperative. And neonatal staff and healthcare providers like us that are caring for very low birth weight infants play a critical role in advocating and supporting mothers in NICU lactation. So that's us. We are staff and healthcare providers. So as we start, I want to think about whether I want us all to do some self-evaluation on if we're playing the critical role that we can in supporting and advocating for possibly for change in your unit. So this clinical report from the American Academy of Pediatrics is a guiding light for our Optimizing Newborn Nutrition initiative. We hope that you're referring to it frequently if you are working in an NICU. If you missed last month's presentation from Dr. Brenda Poindexter, the Chief of Neonatology at Emory University, she's one of the co-authors of this document. That webinar was recorded, as are all of our webinars, and they're available at GaPQC.org. So check that out. I'll reference a few other of our resources throughout the presentation today. So it's considering that breastfeeding is the biological norm and therefore developmentally optimal, and also recognizing that higher doses of mother's own milk are associated with increased health benefits. It's a dose-dependent scenario. We often hear things like, you can work on breastfeeding once you get home out of the NICU, or I hear parents say, I'm going to wait until we're discharged to work on breastfeeding. So I kind of wanted to just first start off with, like, why is it even important that we work on direct breastfeeding in the NICU before we talk about how to assess it? It feels like passing the buck when we communicate to parents that they can work on breastfeeding at home. And there's two main reasons that putting off breastfeeding isn't a good idea. One is that there's a lack of skilled IBCLCs in most communities that are going to be available to support that dyad after discharge. So if your hospital has an outpatient clinic with skilled IBCLCs that are able to support them, then that might be a rarity in my understanding in Georgia. But you're a little bit off the hook there, but there's still lots of good reasons to work on breastfeeding as soon as possible. Another reason why it's not okay to kind of pass the buck and say work on breastfeeding later is that it's really challenging to continue exclusive pumping after discharge. Mothers, when they find themselves now 24/7 in charge of caring for their infant, they will rightly dedicate time to their baby that they had been spending with the breast pump, and their baby, of course, should take priority there. So it becomes their focus and not the breast pump. And So we see a lot of attrition of mothers even who were able to exclusively provide all the milk their baby needs in the NICU. When they get home, if they're still exclusively pumping, they often will stop. And this is why direct breastfeeding before discharge is going to mean more milk for our patients in the long run, in the short run. So breastfeeding in the NICU is not something that's supposed to happen all at once, like the baby's going to be discharged tomorrow, come help this mom breastfeed. It's really supposed to be more and works better as a journey that has lots of steps. And we've reviewed these steps in previous webinars and in micro lessons, and many units in Georgia are already focused on a lot of these steps. The trick is really tying them all together for any individual patient and their parent. So the first step, of course, is oral care or immunotherapy with expressed colostrum or mother's own milk. And then as soon as the baby is stable enough, we want to be facilitating regular skin-to-skin contact. And this can lead right into, if mother is expressing milk prior to the skin-to-skin contact, right into promoting and encouraging any feeding cues where the baby is going to the breast, seeking out the nipple. I was in San Diego this last week and got to see this in action at the UCSD NICU, where they have the We Nuzzle program, and I hope that they'll come and present that to us. But this idea that there's really a step between skin-to-skin contact and non-nutritive breastfeeding, I think is interesting to discuss. So non-nutritive breastfeeding, of course, is encouraging the baby to latch on a breast that's already been expressed. And then when we are ready to do PO feeding, prioritizing first PO feed happening at the breast. So the first time the baby is able to eat by mouth, and when we're introducing eating by mouth, that happens at the breast, especially when we've identified that is the maternal feeding goal. And then, of course, moving from that first feed into regular but intermittent direct breastfeeding, and then more and more direct breastfeeding as we get closer to discharge. It sounds simple, right? However, by the time that some NICU patients are ready for that oral feeding, the supply of milk available may already be compromised. So as we've discussed before, it's important to really reorient our resources and dedicate lactation support to mothers of NICU patients, starting even antenatally when we can. If we have a mother who's in a high-risk OB scenario or admitted on bed rest, that's a great time for your NICU lactation consultants to consult and provide education. And ideally, this is done by NICU IBCLCs because it's such a different educational scenario and skill set in terms of supporting someone who's going to be pump dependent and trying to establish their milk supply with a breast pump alone. So many of you are already working to identify and train a cohort of IBCLCs in NICU lactation support specifically. Folks who can really specialize in that early milk expression, establishing milk supply with a breast pump, and assessing and supporting breastfeeding in preterm and medically complex infants. And the idea here is to really kind of move to an active lactation care management model, meaning that we are supporting mothers with coming to volume independent of what the baby's feeding order is, rather than just waiting to consult lactation when we run out of milk or when we notice that the supply is low. So before we go further, I just want to remind our group that the Optimizing Newborn Nutrition Initiative has this global aim to improve breastfeeding outcomes for mothers and babies in Georgia hospitals, but we have this particular SMART aim around increasing the percentage of newborns in Georgia hospitals that are receiving human milk as their first feeding. And some interventions that we've identified to achieve those aims are around increasing the number of mothers that are breastfeeding or expressing milk within the first 6 hours of delivery. So the idea here is that by focusing on the early actions of expressing or breastfeeding in the first few hours and measuring how many babies are receiving human milk as their first feeding, we are hoping to affect the outcomes that you've already been measuring, like percentage of infants that are receiving mother's own milk at discharge. And again, as a review, you may remember this diagram. This comes from a 2023 article in the Journal of Pediatric Nursing around keys around coming to volume. And remember, coming to volume means more than 500, the mother is producing or collecting more than 500 milliliters of milk in a 24-hour period. And we're looking for that to happen in the first 2 weeks of the baby's life. So this kind of is reorienting education and resources to ensure that mothers separated from their infants have an effective pump for home use, that they know how to use it, they know how to clean it, how to store their milk, and most importantly, that they are provided an opportunity to understand lactation physiology, and that regular milk removal is the key to a fully evolved milk supply. When we aren't clear about the role of breast emptying and just focus on times per day or how many hours, we can distract folks, and many mothers will wait to feel full before they pump, or they won't use the pump if their breasts don't feel full. So we see things like, pumping on day 2 and not getting anything, and then waiting to use the breast pump again until day 4 or 5 when their breasts feel full. And the evidence shows that early and regular milk expression is critical to communicate to the mother's body that milk is needed, and that especially for parents that have lactation risk factors that can often overlap with a NICU admission, such as hypertension, endocrine disorders, etc. So in this graphic, it kind of reminds everyone that they were looking to be pumping 5 or at least 5 times in a 24-hour period, and that we're looking for one of them to be early in the morning between 1 and 5 a.m., and that we're not going more than 5 hours ever in removing milk. Of course, optimally, we're going to see more than 5 times and not going more than 3 or 4 hours. But if we give parents this education to understand lactation physiology, then we avoid scenarios where folks are, not pumping all day because they had things going on and their breast didn't feel full. So I really can't emphasize enough that when we are telling parents that their milk is precious and life-saving to their preterm or critically ill infant, we have to balance that with intentionally providing the support that we know is going to be required. So as I mentioned, active lactation management by the institution places the onus on us as a system rather than the mothers to ensure that we are actively and equitably providing the resources necessary to optimize milk provision, and pair that along with the burden that we're placing on them by saying that their milk is so valuable to their baby's health. So elements of that active lactation care management include that we're providing a consult, education, and care plan prior to maternal discharge, and making sure that that includes that they have a breast pump, instruction, and plentiful supplies to take home with them, and that we're regularly following up with them in the first 7 to 10 days to assess the secretory activation, making sure that they're coming to volume, and that we are supporting oral care, skin to skin, and nuzzling, as I mentioned, as as a medically appropriate, and that we also need regular follow-up to personalize or adjust that care plan to optimize or maintain their milk volume and to facilitate non-nutritive breastfeeding as appropriate. And then lastly, they need that regular follow-up still to support the transition to direct breastfeeding if that is the maternal feeding goal. So lactation consultation with expertise in the needs of preterm infants is an integral part of NICU care, according to the AAP statement. So maternal feeding goal. Why is it important to know what the maternal feeding goal is? So the AAP clinical report tells us that mothers of very preterm infants are more likely to initiate lactation compared with the mothers of term infants. That's because we're doing a good job, I think, of communicating that their milk is really important to the care of their baby. Yet many of these mothers do not meet their own intended feeding goal. So mothers of very low birth weight infants, as we know, face, and really any medically complex baby, face challenges including, pre-existing or pregnancy-related medical morbidities that can contribute to delayed lactogenesis or reduced milk production, even if they did have a healthy term baby that was breastfeeding around the clock. Also, the prolonged mother-infant separation that happens when the baby's admitted to the ICU, dependence on a breast pump to maintain their milk production rather than a baby that's directly breastfeeding, and then competing demands on their time that impede frequent milk expression, and also impede visitation to the NICU, such as requirements to return to work, caring for other children, among other factors. So we, as a multidisciplinary NICU team, can play a critical role in the ongoing lactation support by providing education, institutional supports for milk provision, and medical practices that support lactation. So, in summary, determination and support of the maternal lactation goal is and should be part of the care that we provide. So we are talking today about breastfeeding assessment in the NICU, but this isn't just a one and done standalone consult that's happening. It should be part of the process. So as we discussed, observational studies demonstrate that initial oral feeding at the breast, more frequent breastfeeding episodes, and the earlier gestational age at the time of the first breastfeeding attempt are all associated with longer duration of breastfeeding, both in the NICU and post-discharge. So we'll look at that again. Having the first feeds at the breast, having more frequent breastfeeding episodes in the NICU, and the earlier gestational age at the time of first breastfeeding for preterm infants all equal better outcomes for breastfeeding, more mothers meeting their goals. Oral feedings at the breast have been studied as early as 31 weeks postmenstrual age, and direct breastfeeding can occur as often as the infant's condition and mother's presence allowed. Pre and post breastfeeding weight measurements can be used to monitor milk transfer. So, transition to direct breastfeeding starts with helping folks put their baby to breast regularly. Putting them to breast one time before discharge is unlikely to set them on a path to feeling confident about how breastfeeding's going. I am just taking a second to look at the chat to see if there's anything we need to address. I think we're okay to move forward. So why has our system evolved to de-emphasize direct breastfeeding? There's lots of barriers to direct breastfeeding in the NICU. Despite the potential benefits we've outlined, we've got significant barriers that are impeding breastfeeding, such as that kind of prolonged immature oromotor coordination we see in preterm babies, the mother-infant separation we mentioned, low milk production, and then, of course, the need for fortification of mother's own milk to optimize growth for those very low birth weight infants. This sort of necessary focus on weight gain means we have become a culture that's very volume oriented rather than skills oriented. And as we've discussed, facilitation of breastfeeding requires resources, requires care coordination that we may not currently be dedicating. And one of the barriers to breastfeeding in the NICU is that human breasts do not have milliliter measurements markings on them. So it's hard to tell how much milk a baby got when they're breastfeeding. I kind of wish sometimes that they did. So on one hand, we want to support the biologically normal way of infant feeding. That's over here where we want to be on the right-hand side. But we don't feel confident in how to know if breastfeeding is working well. And this is a gap. Where we are is maybe not much breastfeeding, and where we want to be is more direct breastfeeding. So this gap, we're going to talk about a gap analysis. So a gap analysis is the process of evaluating the current state of the system, process, or knowledge base against the desired or ideal state, the best practice. And the gap represents the difference between where things stand now, where we are trying to get. And this gap can highlight areas that need improvement, such as enhancing knowledge, upgrading skills, or adjusting practices to align with best practice. So in healthcare, sometimes we'll use gap analysis to compare, existing patient care practices to best practices, and the disparities there can help pinpoint areas of improvement, like I mentioned. So that can be around revising policies and practices or providing more education. So if your unit rarely or inconsistently facilitates meaningful direct breastfeeding in your patients, it's important to assess whether this is a knowledge gap, a skills gap, or a practice gap. So in a knowledge gap, that would be, a lack of awareness or understanding. A skills gap is more about the lack of ability to apply the knowledge to practice. And the practice gap is that disconnect between knowledge and practice. So we encourage you to take this topic to your interdisciplinary infant feeding team meeting. If you haven't yet established an interdisciplinary infant feeding team, this is a great opportunity. You could form an ad hoc group to discuss just this topic. You could include nurses, neonatologists, APPs, your dietitians, your feeding therapists, your lactation consultants. You could even include patient families. And the group could look at what some of the root causes are and could decide to collect some data to validate how significant your gap is. And once it's validated, the group could design education, revise policies, or implement new processes. So here's a little visual around that, looking at your root causes, validating the gap by collecting some data, and then designing some solutions that are tailored to your unit, your resources, your goals, your patient population, because we know that those really vary across the state. So moving on to addressing breastfeeding assessment specifically in hopes of making the process less mysterious. I may have skimmed over that in another slide, but one reason that we're not doing this is somehow breastfeeding is seen as very mysterious, and because we don't have those milliliter markings on our breasts. So this statement from the AAP's clinical report reminds us that mothers can be encouraged to begin oral feeding at the breast as soon as the infant shows physiologic readiness, meaning feeding cues, and the infant's level of respiratory support allows for oral feeding. There's not a reason to wait, not a reason to say they have to take X number of bottles or anything like that. We can start at the breast as soon as they're showing physiologic readiness. So identifying patients who are showing readiness for breastfeeding. So part of this is reorienting our mindset that readiness for PO feeding by mouth, that means readiness for breastfeeding. So those are one and the same. Examining the language that we use is important. So signs of readiness can include, they have stable vital signs, that they are showing us some feeding cues that we've discussed before in other webinars. I'll review in a few slides. And then that they have demonstrated the ability or interest in latching and sustaining short suck bursts. You can do that with oral digital assessment or a pacifier. You don't have to use a bottle to see that they've got the ability to latch and sustain some suck pattern. So choosing a breastfeeding assessment tool. It's another good topic for your interdisciplinary infant feeding team. There isn't one universally accepted tool. There's a lot in the literature. Most of them are not oriented to preterm or medically complex infants. And a lot of concerns around them are the kind of how subjective they may be, or what kind of inter-rater reliability there is between different people using the tool. So the first thing I want to kind of address is that NICU admission is variable. Not all NICU patients need the same kind of caution when we're approaching feeding. About half of all infants admitted to the NICU are not preterm infants and therefore may not require special tools or, like I said, all the caution regarding that we would use with preterm infants. So especially if it's a neurologically intact term infant. So keep that in mind when you're talking about who needs this level of assessment. So 2 tools I wanted to kind of review today are the Preterm Infants Breastfeeding Behavior Score, or PIBS, and the Modified Latch Score. We've spent some time on the Latch Score before, and when we send out the follow-up, we'll put links to recordings and micro lessons about the Latch Score. But the Latch, these are both structured clinical assessment tools that have been designed or modified with the preterm infant or medically complex infant in mind. So the Premature Infant Breastfeeding Behavior Scale, this came out in the late 90s, and it's a 12-item checklist, and it can be completed by either a clinician or the parent. And as I mentioned, it's a tool that was developed specifically for preterm infants and specifically to breastfeeding. There's some feeding assessment tools that were designed for bottle feeding that have been tried to be adapted to breastfeeding. But this one measures rooting, areolar grasp, latching, and maintaining the latch, sucking, and looking at the longest sucking burst and swallowing. So those of us who've done a lot of breastfeeding observation in the NICU, it kind of clicked with me because, there's kids who can latch but not stay latched. There's kids who suck but, aren't very organized. There's kids who seem like they get milk in their mouth and don't know what to do with it. So I liked the idea of this scale. And Lober et al. In the clinical Journal of Clinical Lactation a few years ago, June of 2020, assessed this using the preterm infant breastfeeding behavior scale with late preterm infants, and found the tool was reliable and could be used to help clinicians and parents accurately understand feeding patterns and behaviors. And I liked that this the idea that this can help with feeding decisions, and it's not specifically oriented towards volume. It's about feeding patterns and behaviors. So the other one was the Modified Latch Assessment Tool. And of course, latch stands for latch, audible swallowing, nipple type, comfort, and hold. So this is a modified version of this that another NICU lactation consultant shared with me that they were using to help determine how much to give in terms of supplement or topping up after feeding. And so I'm happy to share this with you all if it's something you want to look at. Basically, the idea was that this is done at every time the baby's at breast in conjunction with the mother, because part of it is breast drainage, how much they feel like their breast was softened after feeding. And so it is subjective, but there's a possible score of 2 for each of the elements and a total score of 10. And low scores can identify maybe further intervention or time is needed. And high scores can mean, more and more direct breastfeeding would be safe for this baby. So just a little reminder around responsive feeding. We have a real excellent webinar and micro lesson on responsive feeding, and we can't expect babies to breastfeed well if we're not allowing them to demonstrate feeding cues. And this is something that I've bumped into as a lactation consultant working in the NICU, is like having limited time and having like scheduled times, and not really being in a place where we have the leisure of really unwrapping and placing the baby skin to skin on the mother and really working on positioning and having patience. I think it's challenging in an ICU setting when we're understaffed and may have limited opportunity. The mom got there late and the baby's already hungry. And that's another reason why having this integrated and regular in your unit, it wouldn't necessarily have to be a lactation consultant doing all of this. If everyone in your unit, if more of your nursing staff feel comfortable about supporting moms to put baby to breast. So some of the things that I am looking at that are as important as the number of minutes at the breast are the baby's behavior, breathing behavior at the breast, like we mentioned, that latch and seal, whether we're observing jaw excursions, hearing audible swallowing, but maybe not too audible. We don't want a lot of clicking or choking noises. How organized the suck is, the mother's comfort, her nipple comfort particularly, and then looking for signs of satiety. So we've talked about those early, mid, and late to this idea that the baby is an active participant shift in mindset when we talk about bottle feeding babies in the NICU versus breastfeeding them. We want the baby to be actively eating rather than how much can we get in them. So we want them to have this positional stability while feeding so they can focus on learning to elicit milk and coordinating their suck, swallow, breathe pattern safely. And attaching to the breast is facilitated by that skin to skin time and getting the baby access to the mother with all of their senses. Stimulating the senses, that combination with the positional stability are achieved by maximum contact between the ventral surfaces of the mother and the baby to encourage biologic flexion. And biologic flexion means the arms and the legs are towards the chest with a midline orientation. So contact flexion and hands on either side are ideal to elicit those feeding behaviors and cues we're teaching parents to look for. So I just felt like we couldn't really talk about assessment of breastfeeding without talking about how to optimize, how to set the mother and baby up for success. And then also remembering we need to look for signs of stress in the baby when we're trying to help them to be actively participating in eating. And we're looking for things like, and this applies to bottle feeding too, change in skin color, modeling, cycling their limbs, stiffening, splaying their fingers, saluting, nasal flaring, averting gaze, grimacing, even sneezing and yawning sometimes can be considered a sign of stress. And then when we're talking about feeding assessment, we're also looking for signs of satiety, since we can't say, okay, they took 45 mLs. We're looking for them relaxing their brow, relaxing their lips and mouth as the sucking slows, relaxing their arms and hands. Or some folks who talk a lot about, the relaxation of the infant's arms being a sign of how full they are. They're releasing or turning away from the nipple, obviously, and then really their legs and hips being loose as well. So I wanted to address the concept around time at breast equaling like full feed or half a feed. This has come up pretty regularly recently, and I just want to kind of propose that a policy or practice of equating a certain number of minutes at breast to a certain percentage of the feeding or a certain number of milliliters is not evidence-based. It doesn't account for the state of the mother's lactation, and it doesn't account for the infant's ability to transfer milk effectively. So I'm just kind of putting that out there, that really if we're talking about assessing volume, that pre and post breastfeeding weight measurements are going to be your best bet. The AAP clinical report mentions this specifically. So if volume transferred is at any given feed is really important to the care plan, where this is a baby that's demonstrating nutritive breastfeeding and we're trying to avoid over or underfeeding this baby, then using pre and post feed weights is a good option. And we can offer your unit special training or help with policy development on how to integrate more pre and post feed weights into feeding assessments. So we're going to talk about it a few slides here today. So while test weighing is common in many countries, practices vary, and a lot of places in the world don't routinely use test weights, and that may be your NICU. Concerns around test weighing involve potential interruption of mother-baby interactions, undermining confidence, for the mother if milk transfer is low. Some folks have hypothesized that routine test weights can be over medicalizing and is focusing on the measurements, that volume culture that we were talking about, and it can make breastfeeding feel scary post-discharge when parents don't have the scale available. And then in one survey, nursing staff felt that without the test weights, mothers were more focused on the experience and the observation of their baby during feeds than on just the difference in how much milk was transferred. But qualitative reports have looked at the effect of test weighing and shown that test weighing in the hospital has no detrimental effect on maternal confidence. I think we can talk a little bit about that. If you're seeing that, are you concerned about that, then maybe those dyads weren't a good candidate for test weighing to begin with. So I've got an article that looked specifically at test weighing that I'm happy to share with you guys, but I think some of the barriers, as we talked about, are like some distrust about the process. I hear that from our team sometimes. Is it really reliable? If you don't have the appropriate sensitivity of your scales, then it's not going to be reliable. And if your staff aren't trained to do it, it's not going to be reliable. And then, as I mentioned, concerned for maternal confidence. So those are some reasons, maybe challenges to using weighted feeds, but I think there's some advantages too. So we can evaluate milk transfer during breastfeeding. Once we know or are confident that a baby is transferring milk first, we need to have a good candidate. We can use weighted feeds to guide individualized feeding plans. We can use them to provide objective data to support the parent education that we're providing and to build confidence and self-efficacy. We can use the information to monitor growth and caloric intake. And we can allow more tailored determinations related to NG supplementation after feed. So if we're talking about those early first feeds by mouth and the baby's on NG tube, we know it'll inform us better on how much to follow up with after breastfeeding via NG. So for those babies that are transitioning to full PO feeding, this can be a really great tool. So some scenarios where we probably wouldn't want to use pre and post feed weights would be obviously a baby that's not safe to be feeding by mouth. So unsafe swallow or otherwise restricted to oral feeding. Prior to lactogenesis too. Like if the baby is only 2 days old, it's not going to build confidence in anybody to do a weighted feed because we would not assume that the baby's going to be transferring very much volume. That should go without saying, but just to be clear. And the same with somebody, a mother that has a very severely suppressed milk supply, it's not going to be useful to do a pre and post feed weight. If the most that somebody has ever brought you is 10 or 15 milliliters of express milk at a time, and the baby's 4 weeks old, like it's not going to be helpful. We don't need to count the time at breast as being nutritive. There's not going to be any useful information gathered from doing pre and post feed weights. And then, other situations where a weighted feed could cause undue stress to the baby or to the parent. If weighted feeds feel like they're undermining confidence, it may be that they're being used in situations where we are not confident that milk transfer is happening. So we can discuss pre and post feed weights with parents as a tool to help us know how much to supplement, how much to top up, or we can link it to progress towards direct breastfeeding skills rather than setting it up as a test of whether they're doing it right or whether their baby is going to be allowed to breastfeed. So a couple of reminders about pre and post feed weights. Specially calibrated scale is required. The objective is not to record a weight for the infant, but just to calculate the weight in grams of the amount of milk the baby transferred while breastfeeding. So what's recorded should not be weights. It should be a number of milliliters. A gram is equal to a milliliter. Another thing to remember about pre and post feed weights is we don't need to undress the baby. In fact, the baby should be in a diaper at least so that anything that they are losing on that end during the feeding is included in the weight. So everything about the conditions of the 2 times that we take the weight should be the same, except for that the baby has been fed. And then to just keep in mind that a weighted feed is a snapshot in time. It's not, what they always are going to get at the breast. The amount transferred will depend on a lot of factors, right? Like time of day, how long it's been since the mother expressed milk, how ready the baby was to eat. There's going to be a lot of things that will affect, the number, the volume that we record. So I wanted to just take a moment to discuss discharge planning and not reinforcing that we should not wait until discharge is on the horizon to integrate direct breastfeeding into the plan. Mothers and babies both need time and practice. When we're developing post-discharge feeding plans, we should be optimally trying to balance the need for fortification on the evidence, the existing, basis of what that individual baby's nutritional and growth status is, and balancing that with the mother's breastfeeding goals. And then, considering also the logistical challenges of expressing and fortifying feeds at home should be part of discharge planning. So as a reminder, for more on that topic and this topic in general, our webinar from this time last year from Dr. Shruti Gupta at Yale New Haven is great. Please review it. You can find all of our webinars at GeorgiaPQC.org and go to ONN and go to webinars. I'm trying to think if I can put this link in the chat, but we can do it. You can find it, or we'll put the link in. So in summary, when infants are fed at the breast, it's difficult to assess the volume of milk ingested. So in practice, infants frequently receive a top-up or supplemental volume after feeding. And this can undermine confidence in breastfeeding, but preterm infants are also at risk of over supplementation or under supplementation with potential detrimental, metabolic outcomes or disinterest in subsequent feeds. And under supplementing, of course, can result in poor weight gain, suboptimal nutrition, a lack of energy to feed well. So we're looking for a way to address this pattern of low breastfeeding rates in the hospital and high attrition of pumping after discharge. That happens even when we know our parents understand well that their milk is important to the health of their baby. So we need to kind of give more consideration to what interventions we can implement that can support mothers to establish and continue breastfeeding their preterm infants. Despite structured approaches to clinical observations, none of them are really correlated with successfully quantifying milk transfer. So it's important to use pre and post feed weights when that's important. And test weights have demonstrated agreement with feed intake when they've been studied in controlled environments. So they still remain the standard in terms of clinical assessment of milk transfer as pre and post feed weights. We discussed some of the challenges to pre and post feed weights. So we need to be careful about choosing, when and how to use them. And just as kind of a wrap up, I think it's important to have a pragmatic approach to kind of combine the clinical assessment of the feeding and the skills that the baby's demonstrating with the pre and post feed weight tools as a measurement of volume, and that we need a pragmatic or practical application of using both of those things in our policies. So I hope that some of you, I left some time, I talked fast enough to get some feedback. I know I saw a lot of folks in the audience that are working in the NICU. So I'm interested, what of this appealed to you? What do you challenge about it? And what are you experiencing in your NICU?
Okay, give me half a second and I'll stop the recording so we can chat.
Yeah. And I will stop sharing.